Welcome to this talk about irritable bowel syndromes. I'm Anja St. Clair Jones. I'm a consultant pharmacist in the UK, specialising in gastroenterology. I would like to talk about irritable bowel syndrome and the pathophysiology, but mainly about management strategies for IBS and looking at what's in the pipeline emerging approaches to treat IBS, as well as patient-centered care approaches, which is very near to my heart. The pathophysiology of IBS is very uncertain. It used to be a functional disease, but now they classify it as a disorder of the gut-brain interaction. The gut-brain axis is a bidirectional highway which sort of exchanges signals to coordinate functions either way between the two organs. And somehow in IBS, this results in chronic abdominal pain and altered bowel habits without any identifiable cause of these symptoms. In 2021, a large multinational study found that about 40% of people suffer from IBS worldwide. That has a big effect on productivity loss in any population. IBS is characterized through the Rome 4 criteria, which is a consensus criteria by a big group of gastroenterologists. It describes IBS as at least pain for 1 day a week in the last 3 months associated with 2 or more of these following criteria, such as pain related to defecation or change of frequency of stool or change of appearance of stool. Any of these symptoms need to be referred, or anybody with all these symptoms need to be referred to a GP for diagnosis, who then will look if these symptoms had onset at least 6 months before diagnosis. As I said, the pathophysiology is uncertain, but we know that lots of factors play a role in the expression of the symptoms. Gastrointestinal motility, hypersensitivity, inflammation, all can have an effect on the symptoms. Post-infection, we know that antibiotics can trigger an IBS flare, or alteration in fecal microflora. The biota of an IBS sufferer is very different from a healthy person. Intestinal bacterial overgrowth, SIBO, we're not sure if that makes IBS worse or is it the symptoms of it. Food sensitivities, but we know there's a genetic component that some patients are more susceptible for it. And there definitely is psychosocial dysfunction that influence the expression of IBS. The Rome 4 criteria classify the IBS into 4 subtypes. We have with constipation IBS-C, we have IBS-D where predominant diarrhea is a symptom, and then we have IBS-M where you have a mix of bowel habit, you have constipation, you have diarrhea, and they are sort of both present, alternate incidences. And then you've got IBS-U, which have a typical IBS symptoms, but it's not clear if it's constipation or if it's diarrhea. So the symptoms suggestive of IBS are chronic and recurrent abdominal pain together with altered bowel habit lasting at least 6 months. However, if you have any of the following red flag symptoms, these patients need to be referred very quickly. You have unexplained anemia, gastrointestinal bleeding, weight loss, swollen lymph glands, abdominal mass, somebody who has a family history of cancer and presents with these symptoms, or onset of the symptoms once you're older than 50 and haven't had any colon cancer screening, or these symptoms happen suddenly and the change of bowel habit is very acute, they need to be referred to a medical practitioner for review. So how do we manage IBS? Well, the key considerations are that it's symptom-based, so any patient needs to be diagnosed with IBS, but then the treatment is based on the subtype. You need to build a trusting relationship with the patient. Patients aren't going to talk to you about their diarrhea or their constipation unless they trust you. And also manage patients' expectations. Symptoms can be controlled, but we can't cure the disease at the moment. We can manage and maintain remission if we have really good strategies in place for the patient. Encourage lifestyle modification, make sure they exercise, make sure they sleep well, and that they have a regular lifestyle. Brain gut behavior therapies are very active, very effective. CBT has a lot of evidence. And also think about providing dietary advice depending on the subtype. So if somebody has diarrhea, do they need insoluble fibers, whereas somebody with constipation might probably need a laxative. Consider FODMAP, which is an exclusion diet where it's appropriate. They may want to consult a dietitian. And then there is, of course, the pharmacological treatment when needed. So for IBS constipation, we usually use laxatives. We have bulk forming agents such as aspergillus husk, chia seed, linseed, but then also the osmotic agents like polyethylene glycol or macrogol. We do not recommend lactulose because that breaks down into gas in the intestines and therefore can worsen the IBS symptoms. If these not work, then we could consider pharmacological approach with linaclotide or plecanatide, which work fairly quickly, or if they don't work, you could use lubiprostone or tenapanel, which have different mode of actions. All these last ones need to be reviewed in 4 weeks, and if they don't have any effect or the patient is not responding, they need to be stopped. They're not going to be effective after that time if they haven't been already. IBS-D is diarrhea. Obviously, we use antidiarrheal like cloperamide, so opioid agonists. The onset is very quick, and you could consider bile acid sequestrants like cholestyramine or cholesevelam. But again, if they don't work, then you stop them within 2 weeks. Non-absorbable antibiotics could be used. I suggest to always consider, of course, resistance. Rifaximin is basically sterilizes your gut, and you take it for 2 weeks, and then you need to stop the treatment and review again. It might be cyclic, but I think that if patients respond to rifaximin, they might be reviewed by a practitioner. You could use the selective 5-HT antagonist alocetrone or the eluxadolin, which is a mu or kappa opioid receptor agonist together with a delta receptor antagonist. All of these need to be reviewed in 4 weeks and stopped if there is no change in symptoms. For IBS-M and IBS-U, the approaches are slightly different. IBS-M, you need to rule out that they have not constipation with fecal overflow incontinence. And we don't usually recommend treatment for diarrhea or constipation, because you could make either of the symptoms worse depending on the treatment. So focus on dietary advice, and also, of course, treat the global symptoms, which we talk in a minute about. IBS-U, there are no specific guidance available. They basically suggest to treat on best clinical observations. So if somebody feels they have more diarrhea or more global symptoms or more constipation, align the treatment with the most prominent or distressing symptoms. So that's why you need to know the patient to find out what is important to him and what is affecting his life most. So global symptoms are mainly the bloating, the pain, and all the other uncomfortable symptoms of IBS. So you have antispasmodics, you have mebeverine, works very well, take it before food, and it works immediately. You could use anticholinergics such as hyoscyamin, either sublingually or orally. Again, quick onset. Or we could use peppermint oil or peppermint tea to help with the bloating and also some of the sort of muscle relaxant, the pain. Some patients respond very well to tricyclics, and the only disadvantage is they take quite a while, and they're obviously prescription only. And then obviously, again, there is the antimicrobial, which might help if there's an infectious component. Emerging therapies are basically looking at the gut biota, and you use probiotics or prebiotics, or you join it in the symbiotics. So probiotics are actual live bacteria which have a direct benefit to your gut flora, and it could be just one bacteria, or it could be a multiple of them. Prebiotics are substrates that feed the bacteria, either the one in your gut, or if it's combined with the probiotics, it's either feeding the probiotic, the bacteria in the probiotic, or it feeds the together with the change of bacteria, it feeds the existing bacteria. So it's either synergistic or complementary. I have to say that we don't really know which bacteria, how much of the bacteria, and what combination of bacteria. So this is all very still being investigated, but we know that some patients respond really well to probiotics or symbiotics or prebiotics. It's just worth a try. The next one is sialoglucane, which is a plant polymer, and it forms a mucus which protects the mucous membranes. So the idea is that by covering and adhering to the mucosa, it becomes like a barrier and restores the permeability or the barrier function of the gut. So it reduces the hyperpermeability, which is usually goes together with IBS symptoms. It adheres very well. It's a really safe treatment. It has no adverse drug reactions, and it preserves these tight junctions and makes the gut wall much more cohesive against anti-invasive bacteria or toxins. It's often combined with pea protein, and together they act synergistically to reduce this hyperpermeability which might be present in the intestines with IBS. Interestingly, that this xyloglucane is combined with the pea protein and laxatives for treatment of IBS constipation. It's often combined with prebiotics for IBS diarrhea or probiotics. And for IBS-M or for the global symptoms, it often is combined with natural substances. And there is lots of evidence that xyloglucane and pea protein are much more effective than when compared with simeticon. All these treatments don't seem to have any adverse drug reactions, and they seem to improve the symptoms within a month or so. So they are very promising treatments. So patient-centered care approach, as I said, form a relationship with your patients so they are comfortable to talk about their symptoms, which, to be honest, is not something you easily talk to people to. Refer them to a medical practitioner for diagnosis if they haven't got the diagnosis and you expect IBS, and particularly if they have red flag symptoms, and educate the patients. Educate them about IBS, what it is, and about the gut-brain axis, and manage their expectations about what's possible to expect from treatment. Advice on lifestyle and dietetic advice, and review current drug history. It could be that it's just one of their medication that causes the constipation or the diarrhea. And take into account the symptoms for treatment of choice. So severity, subtype, and also please individual preferences. Not everybody likes medication the same way, and you need to find what suits the patient. Take the patient's beliefs and wishes into account. It should be a joint decision-making because every patient responds differently to treatment, but also the acceptability of treatment is very varied from patient to patient. And always review the effectiveness of treatment after 4 weeks, and after that on a regular interval. Therefore, as a summary, the pathophysiology of IBS is not well understood. It's a disorder of the gut-brain interaction. IBS is very common, and it is a multifactorial disease, which I would really like you to make sure you recognize red flag symptoms. Discuss lifestyle and dietary changes and establish a management approach. Pharmacological treatment should depend on the subtype. And with the emerging treatments, we might have some very effective new products that can be combined with established treatments already. They offer potential restoration of intestinal permeability, and they don't seem to have any additional adverse drug reactions. Always consider patient-centered approach, involve the patient in the management of their IBS. They need to accept the treatment to be most effective. Review the effectiveness after 4 weeks, and you may want to change the treatment strategy, and always consider comorbidities and drug histories. Here are some guidelines you may want to read and useful information sites, and particularly patient leaflets, which might help you discuss the treatment with the patients. Thank you very much for listening.